I'm Clare Davenport, and I'm here with Sue Mallett and Bada on behalf of the QUADAS-3 steering group to present QUADAS-3 to you. QUADAS-3 is an updated tool to evaluate risk of bias and applicability concerns in diagnostic test accuracy studies, as Rachel introduced. So just to give a bit of background, QUADAS-2, which was the previous risk of bias and applicability tool, was designed in 2011 for test accuracy studies. And QUADAS-2 is widely cited and used, and it's recommended by major HTA organisations. And although the feedback on QUADAS-2 was generally positive, there had been some problems identified with some of the signalling questions, and it was felt that the tool could be improved based on features included in more recently developed risk of bias tools, such as Robin's Eye and ProBAS QUADAS-C, for example. So today we're going to introduce you to QUADAS-3, which is the updated QUADAS tool. We're going to outline the methods we used to develop the tool briefly, and then we're going to work through an example assessment to illustrate the structure of the tool and some of the changes that have been made from QUADAS-2. And just to note, there are 2 publications available associated with the tool. So there's a publication which outlines the development of the tool and contains the tool itself. That's on the left. And then there's also an explanation and elaboration guidance document to help you to apply the tool. So there were 3 main development steps. The first was identification of evidence, and I'll talk a little bit more about what that evidence was and how we used it. We held a face-to-face meeting of the steering group and the advisory group in 2023 at the Cochrane Colloquium. And then we undertook several exercises to pilot and refine the tool. And throughout the period of development, we started in 2019 with a bit of a blip for COVID. There were regular meetings of the core group. So step 1 then, identification of evidence. Several aspects to this. So the first thing we did was we looked at modifications to QUADAS-2 that were made as part of the Cochrane Handbook for Diagnostic Test Accuracy Reviews. We looked at developments that had been made from more recent risk of bias tools. I mentioned a couple at the beginning, so QAPAS, QUADAS-C, ProBAS, Robin's Eye, for example. We reviewed methodological studies that had evaluated QUADAS-2. So there were just 3 studies that we found that had done that. We looked at published systematic reviews that had used QUADAS-2 in 2019. So we looked at 66 reviews that had used QUADAS-2. We undertook a web-based survey of review authors who'd used QUADAS-2, and we had 53 authors responding to that web-based questionnaire with varying levels of review experience. And we also reviewed guidance that had been produced by HTA organisations about how to use QUADAS-2. In the face-to-face meeting of the steering group, so step 2, we reviewed the evidence from the previous step, and we used that to help us decide what the scope of QUADAS-3 would be. We considered whether we should continue to include applicability assessment within the tool. So QUADAS is a tool to assess risk of bias and applicability. So it's a quality assessment tool, not just a risk of bias tool. We decided to retain applicability whilst recognising that we probably need more empirical evidence around that area. We considered the feasibility of using algorithms for arriving at domain level ratings. These are present in other risk of bias tools, but actually concluded that it was just a bit too complex and would actually not help users with the tool to have these. And then we undertook some small group work to come up with a first draft of the tool. And then step 3, which was piloting and refining the tool, we first of all shared a tool with our steering group for feedback, for a wider steering group. We considered incorporating QUADAS-C in QUADAS-3 and decided against that at this stage. QUADAS-C probably will be undergoing some further development. So at the moment, QUADAS-3 does not include QUADAS-C, a separate tool for situations where you have comparative primary studies of test accuracy. We piloted QUADAS-3 on 5 papers with the steering group, and those 5 papers are now available as worked examples on the QUADAS-3 website. We also piloted the tool at the Global Evidence Summit at a workshop. I think 16 people attended that workshop, reviewers with various experience of doing quality assessment of test accuracy. We undertook a series of Think Aloud interviews. We piloted the tool in some real systematic reviews. So I think 6 systematic reviews, some of which were current, and prospectively we piloted the tool, and then a couple of reviews that had already used QUADAS-2, and we then applied QUADAS-3 to the studies in those reviews. And then finally, we shared the tool with the steering group for their comments before agreeing on the final version. This is just an overview of the phases of QUADAS-3, the structure of the tool, and the new or changed elements of the tool compared to QUADAS-2 are indicated by the red font. So the first phase of QUADAS-3 is where we state the systematic review synthesis question, noting that there may be more than one question that a review may want to address. The second phase is a new phase in QUADAS-3 where we define the ideal test accuracy trial for each synthesis question which has been defined. The ideal test accuracy trial is a theoretical construct. It's the sort of trial that you would be able to do if there were no ethical or resource constraints for your review synthesis question, against which we can then judge risk of bias and applicability concerns for included studies. And Sue will be explaining that in a bit more detail in her presentation. So it's a reference point against which we assess risk of bias and applicability. Phase 3 remains the same. We draw a flow diagram to illustrate the flow of participants through each study. Phase 4 is a new phase where we identify the accuracy estimates in a study that we want to assess for risk of bias and applicability. So in QUADAS-2, risk of bias and applicability was assessed at study level. In QUADAS-3, we're assessing risk of bias at test accuracy estimate level. And it may be that there are several estimates in a single study, some of which we might want to include in a review, not all, but there are sometimes multiple estimates within one study. For example, if more than one index test is being used, or if an index test is being used at different thresholds, or there are different participant groups. Phase 5 is the meaty bit of the tool, really. This is where we undertake risk of bias and applicability assessments for studies across 4 domains for risk of bias and 3 for applicability. And then phase 6 is the phase where we make an overall judgment about risk of bias and applicability for each selected estimate. And phase 6 has now been formalized in QUADAS-3. So before I hand over to Sue to look at some of the steps in the tool, the phases in the tool in more detail, I'm just going to give a brief overview of some of the generic changes that we've made to the risk of bias and applicability assessments in phase 5. And I'm going to use the first domain in QUADAS-3, which is the participant domain. And on the left of my slide, you can see QUADAS-3 for the participant domain, and on the right was the domain in QUADAS-2. The first thing you'll notice is that there's more structure for support for the support for judgment sections. So there was just a single statement in QUADAS-2. There's more detail to help reviewers on the left to help them to answer the signalling questions further down in the box. There are changes to some signalling questions and the order in which we ask signalling questions, which Sue and Bada will go over in their sections. You'll see that we're assessing risk of bias and applicability at the estimate level rather than the study level. So in this example here, there's only one estimate, but there may be more than one estimate in each study. There's a change to signalling questions. So rather than yes, no, and unclear, we've got yes, probably no, no, and no information. This is in line with more recent tools, and it really encourages authors to make a decision rather than plumping for the unclear category, which is much more useful and valid for the tool. And there's also a change to domain level answers from low, high, unclear to low, high, and insufficient information. And finally, there is a box for giving a rationale for the overall risk of bias judgment that's made. And this is what the applicability section looks like in QUADAS-3 with QUADAS-2 at the bottom of the slide. And again, you'll see that there's more information provided to help reviewers judge the applicability of an estimate, of a test accuracy estimate with reference to the ideal test accuracy trial, which Sue will explain in a second. And again, there is a change to domain level answers from low, high, unclear to low, high, insufficient information. Okay, so that's a bit of a background and an overview of some generic changes to the domains in QUADAS. I'm now going to hand over to Sue and Bada, who are going to take you through an example, which is evaluation of a simple and rapid dipstick assay for the diagnosis of typhoid fever in Indonesia. And this is one of the examples which is included in the QUADAS resources on the website. I'll hand over to Sue.
Oh, thank you very much, Claire. I'm going to now share my screen. So give me a minute. Okay, thank you very much. I'm Sue Mallett. I've been part of the QUADAS team since 2010, as I think Claire has, and I'm going to take you through the different phases. So we're going to start with phase 1, which is about defining your systematic review synthesis question. And remember that quite often in reviews, there's more than one question. So, and what we'll find out is as we, for this example, there is more than one question. Okay, so in this example from typhoid, the first question is, what's the accuracy of dipstick testing for diagnosis of typhoid infection? And that's using one particular infectious agent, Salmonella typhi. And then there's a few more details. Again, the questions define both your participants, your index test, your reference standard, and your clinical setting. So here we're saying we want to do the accuracy of this dipstick testing for this infectious disease agent in adults with symptoms suggestive of possible typhoid in a community setting. Okay, and that's a question nicely laying out all the context of the actual test accuracy. In this article, there was a second question, and what you can see is it's actually identical, apart from the fact it's looking at 2 different infectious agents that could cause typhoid. Okay, so for the rest of this talk, we're going to just talk about question 1, but I just wanted to let you know that when you've got more than one question, you have to separate those out, because obviously their risk of bias will be different for the different questions. Okay, so that phase 1 is stating the systematic review question. Phase 2 is talking about this ideal diagnostic test accuracy trial. And I tend to think of it as where you've got this, beautiful picture of this scene of these fantastic trees in autumn and the sky and the snow and everything. And that's your ideal trial, is the actual image itself of your perfect image. But every study we do is actually not quite like that. It's more like the reflection in the water. Okay, and so with a real life trial, you've got risk of bias, and it leads to slightly distorted results, and that can be due to just how your shortcomings in the design, the conduct, or analysis. And often you can't do anything better than those. Often you've done the best possible trial, but it's still not the ideal trial that you would have done in a perfect world. Okay, and what the definition of the ideal trial does is it actually gives you something to actually look at your actual real studies and say, oh, okay, that's why there's could be an issue, because they've sort of moved away from what would be the perfect trial. And QUADAS-3 provides us with a framework for the ideal trial. Now, this is like, it's laid out in different sections and again, we'll see as we go through QUADAS, these sections of participants, index test, definition of target condition analysis, those are the four structure parts of the domains in QUADAS-3. And so when you're defining the main trial, you're defining them as around those domains of QUADAS-3. And then when you're actually looking at your real studies, you're going back to for each domain, you can go back and look at what you've defined in your ideal trial. Now, we've provided this lovely framework that's printed up within part of QUADAS-3 papers. And here you can see, again, for the domains, we've got all these bullet points of general features you'd want in an ideal diagnostic test accuracy study. And if you're thinking, oh, that's useful, you're right, because it's not just useful in the world of systematic reviews for using your QUADAS framework. This is also a really important table if you're designing your own study. And it's something you'll be coming back to all the time. So when you're doing this as part of QUADAS-3, in some situations, you'll just be copying and pasting exactly the words from this framework. But in others, you'll be adapting it. So here, prospective enrollment of a single group of consecutive eligible patients having the target condition, you'll be putting in your eligibility and your target condition. So you'll just be changing some of the words to make it really just bespoke to your review question. But this, you may also be adding some extra features as well that you know of, but this is a really, really useful framework. Okay, and so if we were thinking about that, I've got a little interactive exercise here. If we were thinking about who will you enroll in an ideal study, I've got 5 groups of people here. Just take I don't think we've got a minute, but let's just take a few seconds to think of who you would enroll. And here's your objective: accuracy of testing for typhoid infection. And then I'm just going to emphasize things in adults with symptoms suggestive of typhoid in a community setting. And it's that bottom bit. Just have a look at those people below and think, are any of them completely out? And I wouldn't have them in my study. Okay, so I'm going to start off talking through who I would eliminate. Babies, they're not adults. So you don't want them in your study. Okay, the next people I got rid of were the people in the intensive care unit. They're not in community setting, okay? The next lot I got rid of are these concerned patients who are attending community care. We wanted adults with symptoms suggestive of typhoid, not just people who are worried. So there'll be a particular list of symptoms, and we want to enroll people who've got those symptoms. So it could either be the hospital patients with typhoid symptoms, or it could be patients attending community care. And so in some settings, the hospital setting is where the community care would be for typhoid. So that's why we've got that setting. So hopefully that helped you think a little bit about, when you're thinking about what your ideal trial design, you're looking at your question and you're focusing on words from that and working out exactly who would be in your ideal trial design. Okay, and that should be people who would get the test in normal clinical practice, and it should be an unselected set of people who would get the normal test. Okay, here's an example, a bit overwhelming, lots of text. Just to let you know, the QUADAS-3 website has worked examples for you, and this is what people did for that typhoid. This is our answer that we came up with as a steering panel, an exemplar for that typhoid test. So this is available to you on the website. Okay, so phase 1, we got the question. Phase 2, we thought up the ideal diagnostic test accuracy design. In phase 3 is a flow chart. Okay, and this helps you understand how patients flow through the study. This is who are eligible, and these are people who were recruited and who had the reference standard, and here's the results down here. Okay, with a bit of luck, the paper you're extracting from followed the STARD reporting guidelines, and they did a flow chart for you, and you've just got to check it. If you're unlucky, you've got to do the flow chart from the actual study itself. Okay, but this is a really useful part of doing a risk of bias assessment, as you can see as we go further through. And so when we've got this flow chart, what you can see here is that there's, for phase 4, we need to actually, we're looking at the accuracy of a particular numerical estimate. Okay, and what we can see is in this example, there's a bunch of different estimates. So there's an estimate just coming from this one Cariadi hospital, and then there's an estimate from 3 other hospitals, or we could combine all of those and put the 4 hospitals together. And there's also stuff coming from negative controls from other febrile diseases. Okay, and basically, as a review team, you need to work out which estimates you're going to put in. And for advanced users of QUADAS tools, you need to have this discussion at the start of the review, ideally, what type of estimates you're going to include in the study. Okay, so I've got some bubbles here, but they're in slightly the wrong place, so I'm going to keep moving. Okay, so you may draw up a table showing the estimates, and here we can see that if we took all those 4 hospitals, we'd have an estimate over here. But if we just focus on one of the hospitals with a slightly different reference standard, we'd have the estimate here. Okay, and it's the estimate that we're actually doing the risk of bias for. And you can see that because these 2 estimates have different reference standards, therefore they will have slightly different risk of bias. Okay, right. And so when you've found the estimate, you'll be filling in, all the features around that estimate. Okay, just to help you sort of really focus on what's going on in the paper. And then we come on to phase 5. And this is where you've already got your questions, you've got your ideal trial design, you've got your flow chart, you've worked out which the estimates you're going to assess the risk of bias are, and here's your risk of bias section. And as Claire talked you through, there's different features about this box here gives you all sorts of hints about the key features and some prompting text to help you with some definitions. This bit gives you the signaling questions that we're going to answer. This is where you choose from your answers. You'll put a ring around the answer that best fits with you. And here's where you'll have your overall assessment of the risk of bias. And then here you're giving the reason for that domain assessment, which is likely based on your descriptions you've written in this top box. And here again, the same thing for applicability of that estimate. You're looking at your domain assessment, and then you've got your rationale. Okay, so we're going to have a couple of quick little interactive bits here. So we're going to look at signaling question 1. Was a single gate design used? Now, this single gate design terminology is not always familiar with people. And so actually what you can see is we've actually provided the definitions of single gate and multi-gate in that hint box at the top. So single gate design is where enrolling patients whose diagnosis is not yet known. Multi-gate is where the people already had a known diagnosis, and this was previously called case control design. Okay, and so what we were really trying to do is look at these people here, our participants, patients with suspected typhoid admitted for hospital, excluding the negative controls. Okay, so are those people where we know the diagnosis when we're recruiting them, or people where we don't know the diagnosis? Okay, so those are people where we actually don't know the diagnosis. If we had included the negative control patients, they would have been people where we knew the diagnosis. Okay, so let's just give you a little focus on having a go at one of the questions yourself alongside me. The next one is, were the participants prospectively enrolled? Okay, and I've got 3 groups of patients here, and I'm going to talk you through those. So let's have a look at the first group. Are those people prospectively enrolled? Yes, they are. So they're people attending community care, and if we include them in a prospective enrollment, and we make that clear in the study, then they're prospectively enrolled. But if we're doing an audit of people who attended last year and we're going back through the notes and looking at everyone from last year, they are not prospectively enrolled. They're people we've just found in the records and included in our study. And the same is true of the electronic patient records. Okay, so again, they're people we've actually, at a time point, we've gone back and looked at the records. We haven't gone forward, recruiting them going forward. So they're not prospectively enrolled. Okay, that could be a bit of a tricky question. And in fact, what you find out in our example for this, for the typhoid infection, we couldn't actually tell whether the patients in the hospitals were prospectively enrolled or not. Okay, so it's not always as simple as you think, and particularly with those questions about prospective enrollment. Risk of bias, again, this is where you go back to your, applicability. This is where you go back to your ideal trial design, and you're seeing whether you think they're the applicable patients. So that's a really helpful thing to do. I'm now going to hand over to Bada. Thank you very much.
Thank you, Sue. Let me share my screen. Hope that works. Yeah, so I'll be carrying on with the rest of the domains. So there are 4 domains in total, and the first 3 domains, participants, index test, and target condition, they address both risk of bias and applicability, whereas the 4th domain, analysis, only addresses risk of bias. In the interest of time, I unfortunately don't have time to go through all of the signaling questions in each domain, but I'll be focusing on the ones that are new in QUADAS-3. In the index test domain, we're mostly interested in assessing how the index test was conducted, interpreted, what information was available to the people interpreting it, and how the threshold for the index test was selected. There are 4 signaling questions, so there are 2 more than QUADAS-2, and the ones with a blue star are the new ones. So let me just go through them. The first one is called, was the index test conducted and interpreted according to the recommended instructions? Second, were the index test results interpreted without knowledge of the reference standard results? So whether there was blinding. Third, whether the results were interpreted with the same information as would be available when the test is used in practice. And the fourth, whether the threshold was either standard or pre-specified. In the previous version of QUADAS-2, this was merely, was the threshold pre-specified? Now we added the word standard. So let me go through the 2 new signaling questions. So this is whether it was interpreted and conducted according to the recommended instructions. The signaling question actually quite speaks for itself. And this is because we find it important that the index test is performed and interpreted in a way that it reflects its real world or intended use. Now, of course, to answer this question, you have to know what the recommended instructions are. And if you're dealing with a commercial test, it's likely that recommended instructions are available quite easily. Otherwise, you'll maybe have to specify them in phase 2 when describing your ideal test accuracy trial. For example, maybe the recommended instructions say that you need fresh blood samples for your test to work, but alas, the study only uses frozen blood samples. So this can be a reason to answer this question as no. However, in order to properly assess the risk of bias, you should also ask whether it is likely that this difference has actually affected the accuracy of your test. Maybe you have external evidence suggesting that it doesn't really matter whether you used fresh or frozen samples. In that case, you can answer this question as no, because they didn't use the recommended instructions, but maybe you can rate the risk of bias still as low instead of high. Now, other aspects of the sample collection is just one aspect, of course. Other aspect that you might want to look at is the type of equipment that is used, how the test was prepared, or who are the people actually carrying out the test, and if it has a continuous test result, how it was dichotomized. And the other new signaling question is about whether the same information was available to the test interpreters when the test is used in practice. Usually, at least some clinical information is usually available before performing a particular test. And this information, of course, can influence how a test is interpreted. Suppose that you're working in the emergency. So the study is in an emergency room setting, and you're looking to evaluate the accuracy of chest X-ray for pneumonia. And in the study, suppose that the chest X-ray is interpreted without any prior information. For example, age, signs and symptoms, and blood test results. The interpreter is blinded to all of those. What do you think? Do you think this would be problematic? Take a second to think about it and maybe provide your answers in the chat.
People are entering answers, Bada.
Yeah, so I can also see the chat.
can see
Yeah,
that,
so we
right.
have at least one yes answer. It would be problematic. In the interest of time, I will also just explain. So I agree. So usually, perhaps in the emergency room setting, almost always chest X-ray is of course interpreted with knowledge of the patient's clinical information. So if this is not the case, then it could constitute high risk of bias. So I agree. So these are our answers to how we would rate the risk of bias in the typhoid study. Due to time limitations, I cannot go through all of them, but hopefully later, if you have the recording, you can take some time to go through these answers. The third domain is called target condition, and it used to be called reference standard in QUADAS-2. You can see that if you are familiar with QUADAS-2, this domain now has a bunch of extra questions, but not all of them are new. A lot of them came from what is called the flow and timing domain of QUADAS-2. That was the fourth domain. So target condition is about how the target condition was assessed and which reference standard was used and how the reference standard was used. And it's also about the time interval between the index test and the reference standard. So the first one is, does the reference standard adequately identify those with and without the target condition? The first three are actually still from QUADAS-2. Was the target condition assessed in all patients? And was the target condition assessed in the same way in all patients? Number 2 and 3 allude to a bias that we sometimes call verification bias, where if you have the reference standard, not a target condition not assessed in all participants, we call that partial verification bias. And if the target condition was assessed differently in some participants, we call that differential verification bias. New signaling questions start from 3.4. Did the reference standard avoid incorporating the index test? And was the reference standard conducted and interpreted according to recommended instructions? You can see that this is the same question from the second domain, so we also put it in here for consistency. 6 is, were the reference standard results interpreted without the knowledge of the index test results? So this is a pre-existing question about blinding. 7 is about threshold, which mirrors the same question in domain 2. And the last one is about whether there was an appropriate time interval between index test and reference standard. You'll probably be familiar with this because this was a question also in QUADAS-2 in the flow and timing domain. I will touch a little bit about 3.4 and 3.7. So did the reference standard avoid incorporating the index test? If you're familiar with QUADAS-1, the very first QUADAS, this question was actually part of QUADAS-1, but it was omitted in QUADAS-2. Now it's back in QUADAS-3. This is about a type of bias that we call incorporation bias, and this happens when the index test is part of the reference standard. Well, if index test is part of the reference standard, so suppose that the index test is positive, then the reference standard is also positive. Naturally, their agreement will artificially increase, and so will artificially accuracy will artificially also be overestimated. And this usually happens when the reference standard is composed of several different tests, something that we call composite reference standard. For example, let's say that your index test is troponin and you want to detect myocardial infarction, and your reference standard is a hospital diagnosis based on all of the available information, including the very troponin result. which means that if troponin result is positive, your reference standard is also likely to be positive. So this creates a problem. So for low risk of bias, ideally, you would like the index test and the reference standard to be separate and independent tests. 3.7 is about reference standard threshold. So this is also a new item in QUADAS-3. So reference standards, just like index tests, they are seldom naturally dichotomous tests. It's really very seldom that you have a clear delineation between diseased and non-diseased. So usually a threshold is needed. For example, consider the case of a microscopic culture, microbiological culture. If you have urinary culture, it's not the case that any bacteria that you see on the culture plate is evidence of a bacterial infection. Usually there needs to be some level of bacterial growth in the culture plate to say, well, this culture is positive. So why would a threshold need to be pre-specified for the reference standard to avoid bias? I'll let you think about it for a couple of seconds, and maybe some of you want to have an answer in the chat. So if you have, let's say, two different possible thresholds for a given reference standard, that means that you can create at least two 2x2 tables, two data sets from which you can estimate sensitivity and specificity. And if you have two data sets, maybe if you didn't specify the threshold in advance, you can maybe see which of the two data sets gives you a more desirable result, more desirable sensitivity and specificity estimates. And then there is the risk of selectively only reporting the data set that you think fits your hypothesis. So this is to rule out the possibility of a data-driven threshold selection. So I'll be skipping this in the interest of time. And the last domain is called analysis. So this is a completely new domain in a sense. It replaces the flow and timing domain in QUADAS-2. And the most of the signaling questions in flow and timing have, as I explained, been moved to domain 3. Now, this is also a domain that only deals with risk of bias, not with applicability. The first question is, were all participants included in the analysis? This is an existing question from QUADAS-2 in the flow and timing domain. New questions are, were missing data handled appropriately? Does the unit of analysis match the ideal test accuracy trial? So unit of analysis meaning, were it participants, or were they composed of samples or specimens or organs? And the last one is, were the estimates of sensitivity and specificity calculated appropriately? I'll be touching on the ones 4.2 and 4.4. So even if we have the question about were all participants included in the analysis, if there is missing data, of course, you would like to know how those patients were included in the analysis. How was missing data dealt with? And in general, very broadly speaking, missing data can arise from not receiving the index test or the reference standard, or both. Or maybe patients did receive the tests, but results were unusable or uninterpretable. Then we can have missing data. Generally, the appropriate method for dealing with missing data depends on the missingness mechanism. So your assumptions regarding how you think missingness has arisen in the study. There are many, many different methods to deal with missing data. Unfortunately, by far the most common one is complete case analysis. So that just means you ignore missing data. And this is, although extremely common, this is usually the worst way to deal with missing data. And you could argue maybe it's only appropriate when data is missing completely at random, which is rarely the case, because to be missing completely at random, you would need something like data destroyed in an office fire, for example. Some diagnostic test accuracy study, we see that they do single imputation, so they just fill in likely values for missing data, but only for a single data set. Usually what is more considered appropriate or recommended and rigorous is multiple imputation, where you try this imputation for multiple data sets and then you combine or pool the results. Another method for dealing with missing data is inverse probability weighting, where you try to reconstruct a pseudo population. And there are many other different methods. But if you're not a statistician, you might perhaps want to consult a statistician if you see a method which you are not very familiar with. The very last signaling question is, were the estimates of sensitivity and specificity calculated appropriately? And you might think why this question is relevant, especially if you're doing a systematic review where you're taking the 2x2 data directly to perform a meta-analysis. Well, this question is mostly relevant when you are not directly extracting 2x2 data, but you're directly extracting the reported estimates of sensitivity and specificity for your systematic review. Why would you like to do that? Well, because maybe complex methods were necessary to estimate sensitivity and specificity correctly. For example, maybe study has multi-level or clustered data, or the study authors adjusted for a form of bias, for example, verification bias. Or maybe the reference standard was imperfect, so the study authors decide to conduct a latent class analysis. So when these complex methods are used, you would probably like to extract the reported estimates as well. Of course, if you're not a statistician and you don't know what a latent class analysis is, it's probably a good idea to consult a statistician to assess whether the methods were applied correctly and whether the assumptions were valid. But even very simple calculations errors without these complex methods can often go in the wrong direction. For example, consider the following. This is not about typhoid. This is about a disease called leptospirosis. The index test is what we call PCR, polymerase chain reaction. And here you see that there are 3 positive PCR results among 33 reference standard positives and 11 PCR results that are positive among 754 reference standard negatives. Now, just take a quick moment. We don't have a lot of time, but just take a quick moment to see whether you think the estimates of sensitivity and specificity make sense. Yeah, we already see that Katie, you spotted that, yeah, indeed, sensitivity and specificity were turned around. And if you also calculate what is now written as specificity, but is actually sensitivity, you will never, 3 divided by 33 is 9.1 and not 9.38. So I would generally recommend in any diagnostic accuracy study, if you're willing to extract the reported estimates of sensitivity and specificity, to maybe conduct a small check whether the numbers are actually correct. All right. Then that was all for me, and I think I'll give the word to Claire.
Thank you, Bada. I'll just share the last few slides. Great. So Bada and Sue have taken you through the 4 domains, and I'm just going to present now a couple of slides on how we make overall judgments. Firstly, at the domain level, so there are 4 domains, and then overall across domains. And QUADAS-3 now provides more formal guidance about how to do this, particularly at the overall across domain level. So its signaling questions are phrased in a way that an answer yes suggests that the risk of bias can be judged low, and if the answer is no, then the risk of bias can be judged as high. And we to operationalize QUADAS, then probably yes is usually grouped with yes and probably no with no for the purposes of making judgments. And then there are multiple signaling questions in each domain, and we make a judgment across all of those signaling questions at domain level, whether the risk of bias is high, low, or there's insufficient information to make a judgment. Generally speaking, if all signalling questions for a domain are answered yes or probably yes, then the risk of bias across the signalling questions, so at the domain level, would be judged as low. And if any signalling questions are answered no or probably no, this flags the potential for bias. An estimate at domain level could still be at low risk of bias, even if one of the signalling questions are answered no or probably no. And this is where review authors should agree how they're going to combine signalling questions to come to this overall domain level judgment. And the insufficient information category should only be used when there is insufficient data to allow a judgment. So if we've got all yes, then low risk of bias. If there's any signalling question which is a probably no or no answer, then this flags the potential for bias. And the same applies to applicability, where there are not signalling questions, but we judge each domain, 3 of the 4 domains, I should say. So the participants index test and target condition as being at high or low applicability concern, or there's insufficient information to judge this. And I'm just going to give a couple of examples to show how we might combine signalling questions to come to a domain level judgment. So this is domain 1, the participant domain. And at the estimate level, we've got answers for each of the 4 signalling questions here. And you can see that 3 of the 4 signalling questions have been answered as there being no information available, and only 1 is at low risk of bias. So the overall judgment here for this participant domain is that there is insufficient information to make a judgment about the risk of bias, because 3 out of the 4 questions there's not sufficient information. If we look at this example, which is from the index test domain, we have 2 signalling questions which have been answered yes, indicating a low risk of bias, but 2 where there is no information to make a judgment. So we might consider this a bit of a stalemate. We've got two of one type and 2 of each. And this is where providing information about how you've come to the decisions about these signalling questions in the top half of the domain here helps you to explain what the rationale for your judgment is. So the authors, or well, in this case, the steering group, because this is one of our examples, judged this domain at overall low risk of bias, even though there were 2 signalling questions answered as there not being any information to make a judgment. And this is mainly because of signalling question 2.2, where there was in fact no information on whether the reference standard results were available to the person interpreting the test. But because of the type of study that this was, it's the dipstick result, that's the index test result, is likely to have been available before culture results. So this was probably a prospective study, which means that although we weren't provided with any information, the likelihood is that this is not going to cause bias in this study. And then once all of the domains have a risk of bias judgment, we then need to make an overall risk of bias and concerns regarding applicability judgment for each estimate in each study. And similar rules apply in terms of combining our domain level judgments to come to an overall judgment, in that if all domains are judged low, then the overall risk of bias for an estimate it can be judged as low. But if any of the domain judgments are high, then this flags the potential for bias. And review authors need to make a decision about whether that's a high enough risk of bias that it would bring down the estimate judgment of bias. And here's an example of making an overall judgment across four domains for risk of bias. And you can see that each of the signaling questions the domain level judgments are here. So we've got the participant domain is an insufficient information. Index test is being judged at low risk of bias, the target condition at high risk of bias, and the analysis domain at low risk of bias. Because of the high risk of bias of the target condition, the overall judgment for estimate 1 here is that it's at high risk of bias. Similarly, for estimate 3, we've got a high risk of bias in the target condition domain with the rationale for the judgments here, and this has led to an overall risk of bias for this estimate across all the domains. Whereas for estimate 2, has been judged at insufficient information to make a judgment. And here's the similar table, but for the applicability concerns. Much similar, it's much easier here to make an overall judgment because there is so much red, so much risk of bias. So phase 5 is we have to include judgments at the domain level across signaling questions, and then phase 6 of the tool is where we make an overall judgment about risk of bias and applicability across domains. So this slide just provides an overview of the main changes to QUADAS-2. It's also included in the published paper, and they're bolded here just for ease. So we're making assessments of risk of bias and applicability concerns at the estimate rather than the study level. We have included that we can have multiple synthesis questions in phase 1. We've introduced the ideal test accuracy trial against which we assess risk of bias and applicability concerns. And we've introduced a formal section for making overall judgments across domains. There have been changes to domains and signaling questions in the middle of the slide. Sue and Bada have gone through some of those. And then some changes that we considered but have not introduced at this for this version of QUADAS is the use of algorithms, integration of QUADAS-C, and moving from signaling questions to statements. So we've stayed with signaling questions at the domain level. Where can you find resources for QUADAS-3? There's the QUADAS-3 website where the tool, the guidance document, and the 5 worked examples can be found. And then there's QUADAS-3 paper and the explanation and elaboration document in the Annals of Internal Medicine. And I'd just like to acknowledge the wider steering group on this slide here, who helped it throughout the process of developing QUADAS-3. Thank you.
Fantastic. Thank you so much to all the presenters. That was fascinating. And wow, what a huge amount of work to and collaboration to come together to create the tool. I'm not seeing, we've got a couple of minutes. I'm not seeing any questions in the chat. I have a very quick question, if that's okay. I was interested in the risk of bias kind of relating to missing data in DTA studies. And I guess I wondered, is missing data perhaps less frequent than you might see in intervention reviews? I was just thinking perhaps because you don't tend to lose people between index test and kind of reference standard, or maybe it's equally a problem. I just wondered if you had any thoughts on that.
Shall I first have a go? I think it is very much a problem. At least in the studies that I read, missing data is quite frequent. And yeah, but so you have an interesting point there. Maybe not as frequent in, let's say, studies with a follow-up, because the time interval is quite short for people to drop out. But what is usually often the case is that not everyone that gets the index tests produces a usable result. So often results are, there's sometimes test failure, sometimes there is a result, but you don't know how to interpret it. So there can be missing data from there. And even people who do get the index test sometimes don't get the reference standard. Maybe the participant refused. And often diagnostic test accuracy studies, you'll see that they're often retrospective and not prospectively conducted. So then you have to depend on what is essentially just available data. And you just have to hope that for each participant, you have an index test result and a reference standard result, which is unfortunately often not the case.
Brilliant. That's great. Thanks, Bada. Okay, I think we've got time for one quick question from Terpsy. Thanks for a great webinar. Can you confirm, has QUADAS-3 now officially replaced QUADAS-2? And would you recommend using QUADAS-3 for any new systematic reviews that you start?
Yes, QUADAS-3 has replaced QUADAS-2, and we would recommend using QUADAS-3 for new reviews. The caveat is that, of course, people who are partway through a review using QUADAS-2 probably would want to continue with that. And at the moment, I understand that we can't use QUADAS-3 in Cochrane. So there's likely to be a bit of a delay before there's functionality in Review Manager to be able to use QUADAS-3 in Cochrane reviews. But yes, we would recommend it for other systematic reviews.